And then diving a little bit deeper into the data, this is something I didn't come across. Did you notice any differences between race, age, maybe the location, community, academic, geography, anything that really stood out to you?
Yeah, these are very pertinent questions. We are looking at those with regards to what are the differences between the patients who were intensified versus not intensified with regards to their age, race, ethnicity, location, insurance type, comorbidities, socioeconomic status, and at present, we do not have the results available, but they will be submitted in our next publication where we will be presenting these data sets.
That's amazing. I'm looking forward to not only that aspect, but even I'm curious if there's a preferred, doublet therapy regimen or perhaps even a triplet therapy regimen that maybe, the community favors one so or over the others. Because I know we don't have obviously randomized trials comparing one to the other. Doublets were compared to single agent ADT and, triplet to ADT and chemo. So we really don't know. But I'm curious if we have any trends in the community or maybe based on location. Perhaps there can be some trends there as well. Yeah. And you did mention some of your next steps, looking a little deeper into, the patient's, age, comorbidities, who intensified therapy. Anything else you plan on doing with this data set in the future?
Yes, definitely. We would like to look at the possible reasons for not de-intensifying patients, whether they have a different socioeconomic status, race, ethnicity, insurance, or other comorbidities so that we can identify the barriers or challenges with regards to not using the level one evidence in clinical practice.
And I think that's great because ideally, in the perfect world, we'd want that number to decrease from 1 in 5 to really zero patients, correct? I know that there are some patients that perhaps might be more frail, perhaps they're hesitant even looking at the data. But if a patient's, fit, can tolerate anti-hormonal therapy for most, maybe even a fit patient that can tolerate triplet, that perhaps have maybe, some more higher risk features like de novo disease, high volume disease, they really should be getting intensified therapy. So really identifying these patients and maybe counseling them or finding out what barriers exist is huge. So thank you. And I think to close, the final question I have to ask you is, for all of the physicians, patients that might be watching this, what would be kind of your take-home message on treatment and metastatic HSPC? What would be the main message you would like to share with them based on your data?
Thanks. So for me, the main message is that we should try to intensify treatment for our patients with metastatic hormone sensitive prostate cancer at the get-go. We should follow the current level one evidence and guideline-based recommendations for our patients. And we should keep an eye for the new and emerging evidence to identify what is the best possible combination based on genomics as well as disease volume for these patients.
Yeah, I think definitely the take-home message, ADT monotherapy is inferior. We have so many trials showing at least doublet therapy, potentially even triplet therapy. And like you highlighted, it's a very exciting time in prostate cancer with all these trials coming out. So keeping in mind how to identify these patients that are eligible for trials, do they have any new targets? Is there overall survival benefit? So it's going to be a very complicated but exciting field over the next couple of months. So that's fantastic. So thank you so much, Dr. Swami, for sharing your valuable insights on the changing landscape and also just on real world data and metastatic HSBC. I enjoyed our conversation. I think it's very important to, highlight the work that you're doing. It's very impactful, really focusing on what areas we can improve for our patients in the field, in the real world. So hopefully by next year, we have more data, understanding some of these barriers, getting that 20% down to even close to zero, fingers crossed. And I can't wait to see the work that you do next. So thank you so much for joining us.